I do want to correct one thing. The presence of oligoclonal glands is not a surrogate for dissemination in time. It's instead of time, because there is no time element. And one of the things that I've never been able to get an answer to, and if anyone here knows it, is when in the course of MS do oligoclonal bands appear? And if you start very early, these very early cases, might they not be there yet? Do you have a concept for that?
Well, I think they've had data. Over time, the oligoclonal band positivity rate gets higher and higher to 95% plus. And one of the things about MS oligoclonal bands is they do not spontaneously go away, as opposed to other disorders. At the first attack, you can have an expectation of close to 80% being positive with a sensitive assay.
Okay. Suhail, what about neurofilament light or any other markers?
So neurofilament is a cytoskeletal protein that is elevated in the spinal fluid of patients with a variety of neurodegenerative diseases, not just MS. It's elevated in Alzheimer's disease and stroke, probably Parkinson's disease as well. So in that regard, it is not really specific for MS. Studies have shown that it is increased as the disease progresses. And more recently, we know that it is also increased as a result of an acute relapse. We also now know that it responds to treatment. So a variety of studies have shown with the different immunomodulatory medications we have now that the level of NFL goes down as a result of treatment. I think the main advance is that we can now measure it in the serum with more sensitive technique instead of having to do a spinal tap. I think the big question is, will it be validated as a surrogate marker of damage and disease progression? I think we are not there. It needs to be validated, for example, against atrophy studies by MRI. Because it has the potential to be used as a surrogate marker in clinical trials. There's also some data that says that at the onset of MS, if NFL levels are very high, that is a predictor of worse prognosis. So maybe a combination of biomarkers such as oligoclonal bands level and NFL level at the time of diagnosis together might be better predictor of prognosis. So I think it has the potential, but as I said, it needs to be validated against at least MRI studies. And it's not only neurofilament. Investigators are looking at a glial fibrillary acidic protein now, GFAP, looking at tau, looking at other cytoskeletal proteins such as contractin 1 and 2. So all these have the potential, either by themselves or in combination, to be correlates of disease progression and prediction of disability.
When you say disease progression, do you think we can actually distinguish progressive from just disease worsening?
No, at this stage, because we know that it's increased in acute events and in relapses as well as in progressive disease. I don't think you can distinguish. Let's say you're dealing with a progressive population of patients, be it secondary or primary. I don't think it can tell you whether patients are having superimposed relapses or not, unless you do it very frequently. Then you might be able to tell that.
Might it be useful in distinguishing patients who are more demyelinating versus those that have more axonal degeneration?
Possibly, yes, because as mentioned, neurofilament is an axonal neuronal cytoskeletal protein, so you would expect it to be higher as a result of axonal and neuronal damage than, let's say, just demyelination.
Okay. Other thoughts on biomarkers?
Well, I was just going to add one other piece to this, was that there is some non-specific aspects to this, where it goes up in stroke, it goes up in head trauma, and a variety of other conditions. So particularly in your older population, we may be looking at the marker, thinking it's MS, and it may be other causes for damage within the central nervous system. So we're going to have to figure that piece out.
It goes up with age.
Yeah,
You have to
that
correct
too.
it for age.
And Sohail said there's no specificity to this.
And so I think that's obviously also one of the potential criticisms, that it will work in clinical trials where we have a relatively healthy population and where we also introduce a change by introducing a medication or no medication or a comparator medication in a population with comorbid condition, as was pointed out, perhaps even hypertension in individuals. Obviously, the picture may be much more cloudy, and so from that point of view, it may be more difficult in these patients to prognosticate whether it has some meaning. So I think one needs to stay tuned. This is obviously a protein that has a lot of interest in Alzheimer's, in other conditions. And so from that point of view, it is clearly not a disease-specific marker.